Welcome to Getting Started with Nursing 400. I know we have already done a bunch of things in classes or in labs, and so now it's just really diving into the theory and the content. As it's always good to do is to start with our objectives. So we want to explore tools and techniques used in the high acuity environment to evaluate the stability of the client and their current condition, identify changes in the client's condition to accurately anticipate interventions, prevent complications related to a client being in an unstable environment or situation, and develop critical thinking skills for rapid problem solving in emergency situations or in unstable situations. So as you can see, we are really leaning in to the unstable patient in this condition, and we want to think about what kinds of situations that those can be. They can be everything from young to old. They can be everything from disease processes, acute, chronic, car accidents, all sorts of things. So a lot of things put us in unstable situations, and we have to be able to effectively evaluate what is going on. How is our patient doing? We're really going to be focusing on three main areas of cognition and doing those mental, those like neuro checks and that kind of stuff. We're going to be doing gas exchange, that breathing, and then perfusion. Well, everything else does matter, pain, mobility, all of those things. These three are going to be really our priority focus for this semester. You will see us kind of go off in those other tangents as we explore them, but these three, cognition, gas exchange, and perfusion, are going to be our main focus areas. So we're going to be talking about systems for data collection because creating a system is incredibly important. Creating a system allows you to not miss any data that you may be seeing. Creating that system allows you to get those details that you need, and it allows you to assess quickly and efficiently. So you're really going to want to think creating a system that works for you and creating a system that works for the environment that you overall work in. What all data do you need to collect? So I want you to take a second, think about all the data you need to collect, right? So remember, we're really talking about, especially for these first little bits, we're talking about cognition, we're talking about gas exchange, and perfusion. So if we're talking about those three things, what data would we need to collect? Vital signs, um, level of consciousness, thinking about things like how are they breathing, not just the respiratory rate, but how are they breathing, right? What's that pattern? How is it with ease? Um, what's their color look like? You know, that perfusion piece. How do they feel, right? Are they able to respond to you quickly? All of that is really valuable information, and we're going to want to get that quickly. So when we talk about the order we collect it in, that can be a huge challenge because it depends on where you are, right? Like you're going to get so tired of why and it depends because those are the two things we say a lot. So if you are getting report on the phone, you are not going to be able to do a doorway assessment or a bedside report, correct? Right? You're going to have to wait till they get there. So you are going to go through a different system if you're going through the verbal report, right? If you are doing a shift report, it's going to look a little different than it would if you're doing like a post-op report, right? So depending on where you are and where you're at will depend, but you're gonna want to mainly you want to look at someone, right? So that's that doorway assessment. Look at them. You don't even have to touch them. Just look at them and see, what do you see? What is abnormal? What things are you worried about, right? That will get you hopefully focused in a little bit. So that doorway assessment, you can look at the vital signs if they're on the monitor, all of these things, level of consciousness, um, that the breathing, right? How are they doing with it? Did they respond to you when you walked in that room? What color are they? Do they look like they're struggling? Do they look really puffy, right? Get that. How are they interacting with the people in the room? Are they watching TV? Are they in the recliner? Are they getting out of the bathroom? All of that is important data for you to pull in, and you can get all of that without actually ever touching a patient. Then we want to go kind of down, it goes with that doorway assessment, right? Is what's connected to them. Is there IVs? Is there a vent? Is there drains, right? And this is one reason why I really do love bedside report is because you can run your lines. You hear people say, well, that we ran our lines, right? We run our lines. That way we know everything is connected. We know what it looks like. Some places do it, some places don't. I encourage you always to at least run your lines with people before they go off shift. But you want to just, again, that still could be part of that doorway assessment. You're looking at what they're connected to. Then when you take that next step, you go in and do that head to toe assessment, really focused in on what's going on. Now, you may get doorway and get what they're connected to and get some sort of verbal report and then go get report on somebody else. So you may have some other things that happen kind of in this space. But then you're going to come back and you're always going to start back up at that doorway assessment again, right? Because every time you come in that room, that patient could look different. They could have gone to the bathroom and now they're incredibly pale or can't breathe. They could have been given morphine and now they're sleeping and they're comfortable, right? So we always want to start back at that doorway assessment, kind of look at everything, make sure all the lines and tubes and wires are there. And then we're going to dig into that head to toe assessment. We talked about head to toe assessment, making sure, again, you have the cognition, gas exchange, perfusion. Here you're going to talk to them about pain. You're going to talk to them about, their listen to their heart and get their cardiac rhythms, right? If they're attached to any ventilators, any of that kind of stuff, we're going to get all that stuff. That's all that deep data that you're going to get if something else isn't going on. If a patient complains of chest pain, you're not going to go check their feet, right? Like they're at this point now you're switching to a focused. So at any point in time, a head to toe can become a focused assessment. If there is something that is saying I need to focus on something else. So it's kind of always in this flux depending on. Then, after you're done with kind of all this other stuff, then you may go into your research. And sometimes people put their research before even their doorway, right? You're waiting to get report from someone. You may get in there. To me, research is like your labs, right? Stuff that we're going to evaluate, any diagnostic tests, any procedures that are coming up, right? Any orders that we are looking for, discharge planning, any of that stuff. I call that research, the research part of data collection. And sometimes it can happen before the doorway because you're waiting for report. Sometimes it can happen before the head to toe, right? So again, this is just a system. It's not a perfect one because your patients are going to be ever changing and you're going to be changing and working with them. And depending on your unit, it may change as well. Now we're going to move into our idea of stable versus unstable. So this is a big piece of like always that we've gathered that data, we know what's going on with our patient. Now we want to know, are they stable or are they unstable? And what kinds of things would tell us that, right? So again, our vital signs are going to tell us that. If our patient is their level of consciousness, if they're good and responsive, again, this isn't necessarily in any order. How they're breathing, right? It's going to tell us how they're doing. Any of that kind of information is going to be real helpful to go back to that. Are they stable or unstable? This gets really important with our ICU patients as we're starting to increase pressors or we're increasing sedation. We're going to make sure we're really looking at whether they are stable or unstable. And it's going to be a flex. So I want you to think about what things would I look at as a nurse to think about whether my patient was stable or not. Think about a time when you maybe had someone, a patient, a family member, something that was a little less stable, that was unstable or a little concerning. What things did you look at to see or to start triggering like, I'm kind of uncomfortable with this, right? Our stable patients, they're usually got good fluid volume, they've got good blood pressure, they've got good heart rates, they're tolerating that cardiac rhythm. And then our unstable patients, maybe they're really pale, maybe they're sweaty, maybe they're in pain, maybe they're bleeding and you can visibly see the bleeding, right? So those are kinds of the things that you want to be working at. As you're working with patients, think about where is my patient? And it may change during the day, right? Like at 7 a.m. when you go watch them, they're perfectly stable, they're in bed, they're sleeping, they're doing great. PT gets them up, and all of a sudden they have a massive fluid shift, and it goes to their lungs, and now we are no longer stable. We have flash pulmonary edema, and we have all sorts of problems. So I want you to be thinking about what things would make your patient stable or unstable, and then what data would support it, and how would you go through working with that patient? What things are you going to do about it? The other thing we want to talk about here is we want to talk about the different environments. So I know there's all these jokes about ICU versus emergency room or ED, emergency department, whatever initials you want to talk about. I like to use and because we're really a team. We have different scopes though, right? The emergency room, they are about stabilizing and shipping, right? They want to get them to the level of care they need to be. They're going to stabilize what they can, and then they're going to ship them to the unit that they need to go to. Patients do not stay in the ER. If they do, the ER nurses get very, very cranky, right? Because they're just not used to that level of care. In the ICU, we stabilize or keep stable, right? So we stabilize them or maintain it, and then we let them heal, right? Because here's the funny thing. We all think like, oh, we're going to help people heal. We don't heal people. People heal themselves. We stabilize and maintain it. We give supportive care. We try and prevent complications, right? So that we can allow them to heal. Thinking about that stabilize and maintain so that the bones can heal, right? Like if you get a broken bone, you put a cast on. I'm not healing your bone for you. The cast isn't healing your bone for you, it's supporting it and maintaining it so that it can heal. The other thing we want to think about is the emergency room is pretty abused at this point in time. Like people are using the emergency room for a doctor's visit, right? So people are going in for like everything from ear infections to a cut, from making dinner to having a heart attack. Those are all very different stability patients. And so they work really well on this grid here, which I want you guys to pay some attention to, right? Because this one, this red, right, is resuscitation or what I would call emergent, right? This is emergent. This is no one passes go. You get lots of nurses and all the healthcare team in that room immediately. Look at the things that are identifying for it. Obstructed airway or stridor. That right? That real tight breathing. That means we're going to lose that airway and lose it pretty quick. We may already have a low O2 sat or our respiratory rate is not going to be able to maintain for very long. When we look at heart rate, we're climbing. Our blood pressure is dropping. Those all are things that we're looking at. A GCS or Glasgow Coma scale of less than equal to or less than 8. So we always say like equal to or less than 8 intubate. I always said less than 8 intubate, but apparently 8 you can intubate as well. That is a responsiveness scale that is used. It's very rudimentary. So we always want to make sure we're looking at that. Okay, those are the ones that we're going to be looking at in that first. That's that heart attack person, the stroke person, the person that's been in a car wreck, person's been shot by a gun. As long as it's not their foot, if it's their foot, maybe they're going to go down to the urgent, right? So again, nothing is very black or white or concrete. There's just so much flex in here. Then we get into the urgent, right? So emergent is the red. It's the person we want to go see first, where everybody else is waiting in the waiting room. We're going to get that person in quick. Urgent is their airway is threatened. So that looks like maybe somebody who got stung by a bee and they have a really swollen face, but it's not, they don't have the stridor yet. They're still able to talk. They're still breathing pretty adequately. Their O2 sats are decent-ish, but not crashing. Okay, so like a threatened airway, we're looking at SpO2s, so oxygen saturations of 80 to 89. Might be a little bit more urgent or emergent if it's a kiddo and they're sitting in the 80s, then we get a little more worried, right? So that respiratory rate of in the 30s, we're not going to be able to maintain that long. Heart rate elevated or low, again, making sure we're paying attention to that and that blood pressure. And you can see that GCS. Now we're at 9 to 13. And then we're looking at temps. So the E is for exposure. So we're looking at that temp. So airway, breathing, circulation, disability, I think, and then exposure. So when we're looking at these different things, those are those different letters. But I just want you to think about what's going on with that. When we get down to this yellow, we're less urgent. Oh, all their vital signs are sitting pretty. Their temps are doing okay, you know, thinking about what's going on. Green, somebody that probably didn't need to come to the ED. They probably could have gone to their doctor, maybe even urgent care. You know, they have the flu and maybe they're just not feeling good and they need a little extra meds, or maybe they have a, bronchitis or something, but they don't have a threatened airway. They don't have the bigger issues. So I want you to be really thinking about the difference between ICU and emergency department. Emergency department, going to be taking care of those really quick emergent situations. They don't do that necessarily that full head to toe assessment because they're really focused on what's going on, depending on what they get in. If we get car wreck, we're usually doing a lot because we got to make sure we've got all the glass and all the injuries marked so we know what's going on. Let's see, try to think if there's anything else with the emergency room that we really want to talk about. Things that happen in the emergency room. So you talk about different things they see. We already talked about motor vehicle accidents. We talked about gunshot wounds. We've talked about, heart attacks, MIs, and strokes, right? So those things we've kind of talked about going in. Other things, bites, especially if they're to the face. We get really worried about, especially if they're a kiddo, hypothermia. We got to get them warmed up. Notice over here they had temperatures. When they start getting those temperatures low, we start getting really worried about them. So those are the things that they're going to see, and they're going to kind of go to some immediate actions depending on what's going on. But those, again, they stabilize and then they're going to ship them off to where they need to go, whether it's a different unit, whether it's a different hospital. The only burn unit right now in this area is in Lincoln at St. Elizabeth. And so you guys, Omaha's not going to keep a burn patient. They're going to get them shipped to where they need to be. So let's talk about machines. Just like we talked about, our goal is to help people have support and time to heal from serious illness or injuries. The machines, their goal is to give that support. So whether you think of machines as just that supportive care or you think of them as life support, however it works for you, but machines, their goal is just to support a patient while they're healing, right? To give them that time. So we want to make sure our machines are working. We've already talked, so let's look at this picture here. We've already talked about ventilators, right? So we've got a patient on a ventilator. You can see the tubing kind of going through here. And we can't see, we're not close enough to the ventilator to see the numbers on it. But looking here, this kiddo's got a lot of breaths going. So I'm assuming, just looking at the person in the bed too, they look a little on the smaller side. So I'm betting that this is a picture of a kid in an ICU, which would be a PICU, right? Pediatric intensive care unit. We don't usually keep them in the adult ICUs. We got to send them off to their special ones. There's some specialty pieces that go there. Other machines we have are our pumps. Now, there is not much that an ICU nurse is OCD about. but their lines is one of them. Well, there might be lots of OCD ICU nurses, but for me personally, it's really more about my lines. Like, and then as soon as you get them all nice and pretty, we have to go down to CT or MRI or who knows where else, but we always have to seem to travel. So when you're looking at this patient, you can see that we've got one, two, three, four, five pumps. So we have five different medications infusing at a time. And you notice that we've got some curly tube and it's coming over here. And it looks like we have several different things going on. That's probably some sort of manifold that has lots of different drugs going into it. It's a nice way to organize it. So nurses, they are really particular about their lines. They will, a lot of times they will label them, they will have them ready to go, all of that kind of stuff. So we always want to make sure that we're labeling that line. You can see we've got an ET tube placed in here. And so I'm going to erase some of these so we can still see pictures here. You can see the ET tube is placed, so we know that this is a newer intubation and not necessarily a person that is intubated on a frequent basis or like trach. We also have an OG going there because, right, we want to make sure we're sucking out that stomach or we're getting ready to feed. So other machine that we don't see in here is like a Joey or a kangaroo pump. It's basically a feeding pump, right? We want to make sure people are eating. We want them to have food. You cannot heal if we do not have nutrition. So we have to have some sort of nutrition. We usually start that within 24 or just after 24 hours. So if a patient's been intubated for 24 hours and we're not getting ready to extubate them, we probably need to think about what type of nutrition do we want. And remember, there's TPN, if you remember from your previous class, we've got TPN, and then we have tube feed. So depending, tube feed is better for the gut, right? You don't use it, you lose it. So it's better if we can do tube feed for the gut, and sometimes we'll do something what we call a trickle feed. Means we're going to give just a little bit, about 20 to 30 mLs we might start with at a time, and we just kind of trickle feed them so that we remind the gut what it's there to do, because the last thing you want is for the gut to go the wrong direction. TPN is IV nutrition, and it's going to be in a central line, so that might be something that we look at as well if somebody is really struggling. However, TPN, like you remember, has struggles with the liver, so if we've already got somebody with a liver issue, we may not want to give them TPN. Welcome to the ICU. It's a whole lot of maybes and what ifs and what's going on with them. When you look, here's our monitors. So we want to always be checking out our monitor. And one thing I can see is that we've got an art line going. So that lets me know we're either on some pressors or we've got a pretty sick person, because that art line just bumps us up to that next level of care. I'm not sure what this machine is. It's not one I've seen, at least in that form. My guess would be it's some sort of cooling machine that's trying to keep the patient at a certain temperature for what's going on. But it could be some sort of uh, like dialysis or something like that, although I don't see a lot of tubes going to it, and usually dialysis lines have tubes that go to it. Other machines we have, so talking about dialysis, you might see what we call continuous renal replacement therapy, or CRRT. It's called lots of different things, actually, because when I came from another hospital, it's CVVHD, blah, blah. It doesn't matter. It's continuous renal, it's continuous dialysis, basically. And so because somebody can't handle getting it. Other machines you might see is an intercool. Those, again, that's a cooling machine that goes in the central, usually in the abdominal cavity or in the abdominal vasculature, to helps cool a patient down. If we've got somebody who's got a lot of swelling, we might use that. Otherwise, you might see a hemodialysis machine in the room because these patients are too unstable to leave the room. You might see an intracranial pressure monitor that we use when we're monitoring our head injuries. So you can tell that, I mean, and then there's just all the typical stuff, right? SCDs might be in there, those sequential devices on the legs. We might have that. So there's just a lot of machines that get put in these rooms, and the rooms, no matter how big they are, always seem to get very, very crowded. When you're looking at this kiddo, where would you put him on the stability spectrum? Like, just, again, you're just getting a doorway assessment. of him, where would you put him on the stability spectrum? I definitely wouldn't put him on the stable side, as we've got a lot of, just from what we see, we've got a lot of meds going on here that let me know we've got an art line. I'd want to see some other stuff. It looks like maybe our heart rate's like in the 40s. We're on a ventilator, so we've got a lot going on. I also would want to make sure he has restraints on because I don't see them, so I want to make sure that we get our restraints on and we're taking care of those because the last thing we want is all these tubes and wires pulled out. So that's a perfect example of how to study and how to work with these patients and get stronger is find a picture on Google and print it out, and when you're at your study group, put it in the middle and be like, where are they on the stability spectrum? What are we worried about? What more data do we need? You know, what kind of vital signs we got? What are we worried about? So that's a really great way of working with it. Everything in our body comes, or everything we do comes with a cost, right? If you take Tylenol, we worry about the liver. If you take Advil, we worry about bleeding or gastric challenges, right? So everything comes with a cost. The ICU package comes with a cost. Surviving a traumatic event comes with a cost, right? We'd have to do all these things. So I've kind of broken it down into two main components of it's either a physical cost or it's an emotional cost or a complication. Right. So when we're talking about physical delirium, what oftentimes is called ICU delirium is a big, big challenge for us. It's usually caused from all the pain and sedation and being on a vent and all these things that we do again to support care, but they have more problems because of it, because they lose time, they come off confused. It takes more time for those meds to get out of their system if their kidneys or livers have taken a hit from them. So we always want to make sure that we're paying attention to that. Things we can do to kind of help or prevent some ICU delirium is we can adequately manage pain. So a lot of times they think it's the pain is not being adequately managed, and people are laying there in sedation, tied, restrained, all the things, and they're having pain. So we want to make sure we're adequately managing pain. Think about how you're going to have to evaluate that. That's going to be a very different evaluation than you've done with your faces and all these other 1 to 10 pain scales. Your patient may not be able to tell you, so you're going to have to find other ways. Heart rate, blood pressure, things like that, grimacing when we turn them, that all tells us that they are still having pain and we have not gotten it managed yet. Other things is mobility. Mobility, mobility, mobility. We are designed, we evolved to move. That is what we are supposed to do. Laying in a bed for 7 days, 4 days, couple weeks, not what we're meant to do. Our bodies start to get restless and start to not work well. So when we're working with ICU delirium, one of the things we'll do is we have to get them up. We have to get them moving. We used to have, at the last hospital I worked at, what we called bag and drag, where we would take intubated patients and take them for a walk. It was very challenging, had lots of people there. You had PT, nurses, respiratory therapy, everybody, but it got them up and moving and got their bodies remembering what they were there for, right? So early mobility, if anything, getting them up in the chair, getting them um, moving the arms, moving the legs, getting them moving is so important for helping with that ICU delirium. But really, at the same time, we just got to let those drugs wear off their system, get them reoriented to the room. I had a friend who was intubated for a long time, and then when he came off, he swore he was in a glass jar all the time. Well, he was in BiPAP, which is that full face mask. I'm pretty sure that probably felt like being in a glass jar. Other things we've talked about, and we kind of talked about this before, is infection. Think of all the lines we have, right? So we've got central line infections, we've got Foley infections, not to mention we've got infections if they came in for infections. So then we're starting to worry about like our sepsis. We've got our vent infections, right? So we have lots of sources of infections. We have poor nutrition, maybe they have poor nutrition before they came in. Their body's fighting to keep itself alive, so that increases our risks for infections. So in order to do this, and I know it sounds dumb, but hand washing is our best friend. We're going to want to make sure we're washing our hands. We're going to want to make sure we're wearing gloves when it's sterile gloves, especially when it's important. We're going to want to make sure that we're doing all of our line care, our VAT protocols, and all these kinds of things to try and prevent those infections. We're going to want to get people like turn side to side. We're going to want to make sure we're getting those secretions in the lungs moving through. So we want to try and do as much as we can to prevent the infections from setting in. But if you're in a burn ICU, you're getting infections because that's just you've taken off the skin layers. The biggest goal of the skin is to prevent infection and germ bacteria from getting in. So let's talk about tissue damage a little bit. We all think about bed sores for being in positions. Again, it's one of those things like if we're saving your life and you're too unstable to turn, we're going to deal with the bed sore later. The other thing I like to think about with bed sores is that we all know about cardiac failure and renal failure. No one really talks about skin failure, and bed sores really are a skin failure. It's a pressure ulcer, but it also is a skin is failing, what either lack of nutrition, lack of fluid, too much fluid, right? So then they stretch it all out. So those are the things that we want to think about. I also want you to think about the tissue inside the body, right? If we have somebody who's on a ventilator, their brain is sitting in one spot. Our brains aren't meant to be laying down like that in our skull, so that can cause problems. Our lungs being in that supine position too much can have a lot of fluid that starts causing damage, or the PEEP causing damage, that increased PEEP on the ventilator causing damage to the alveoli in the lungs, right? So there's a lot of different tissue damages that can happen in the ICU. Ways that we can help prevent it. Again, mobility. Sounds dumb, but it definitely is something that can help us getting people turned side to side, getting people up when we can get them up, right? Getting things, minimizing all the minimize, sorry, I can't spell this right this second. Minimizing any the tubes that create pressure, right? So like your IV catheter that's pushing against the hand, causing pressure. The other thing is always be careful of that saline flush. It has that little white cap that comes off when you're giving your flushing a line, but it's a white cap on white sheets. Like I really wish they would make those caps a different color so that we would be able to see them easier in the beds, but white on white sheets. So making sure we don't lose any of our things, right? Like we just don't leave anything in the bed. So lose or don't leave anything in the bed, right? We want to make sure we get any of that stuff out. Okay. All right. So let's talk about some of the emotional stuff that comes with being in the ICU. So a lot of the complications, let's start with coping. You've got families, you've got family and patient, and you have the healthcare team, right? So family and patient and the healthcare team. Family and patient are having to deal with a life injury or a disease process that's gotten out of control or that took an acute turn. Something's going on. So there's a lot of coping with a lot of those big ideas and those big challenges. It can be very, very emotional, especially if they came in for a not so great situation. There's a lot of coping that goes with it. The other thing is the healthcare team. We see a lot. Remember, about 25% of people die in the ICU. So we want to make sure that we're taking care of ourselves as well, and we're not taking care of ourselves through alcohol and drugs and those kinds of things. Like we're doing counseling or meditation or exercise or whatever art, whatever your thing is to help you anchor in. One big thing that I say to people is that it is not your choice, right? We can educate patients every day, and they still have, at the end of the day, have to make their choice and their decisions. And it is not ours to own. So I think that's big to know. It's not ours to own. We have to let them own their own choices, right? It's not ours to own. It's theirs to own. They made the choice. Their family made the choice, okay? That'll get more important as we kind of go around here. talking about families. We've got a lot of family dynamics. We get some real interesting things in the ICU. It gets quite curious. So we're wanting to work with those family dynamics. There could also be financial issues because this person could be the person that is the breadwinner. There may be no insurance. So we're really always working with those ones. Get social work involved, get people there to work with them. But family, they are going to need a ton of education, right, to give them support so they can make the good decisions that they need to make. So we want to make sure that we want to give them a ton of education and break down all of the tubes and the wires and everything in very simple terms. It can be a really big challenge for some of our families because they see their loved one and it's very shocking. The other big challenge that I want to talk about real quick is the ethics. ICU has a lot of ethical issues, and you're going to start seeing them if you haven't already seen them. I mean, oncology has ethical issues, pediatrics has ethical, there's just a ton of ethical issues everywhere in healthcare, but they really come to the forefront in the ICU of do we code somebody who's 99 and has stage 4 cancer? Do we keep someone alive? Even though they're diagnosed as brain dead. Like, right? So, like, all of these ethics start really coming into play here. And again, that goes back to it is not ours to own, but theirs, because we're not going to always agree with decisions that people make. We're not going to agree with them for ourselves personally. And so, we're really going to want to make sure that we, let people own their own choices. Again, we're going to work on that education for them, and then we're going to be really challenged by our ethics. This is where we can be amazing advocates and make sure we're being heard at the table. But again, it's not always our options and not always our choices. So these can be some really big complications that come to the ICU. So I want you to think about, we've talked a lot about different things going on, from complications to the machines that support us, the different types of data we want to collect, and creating a system that we want to collect it in. So I hope this helps and gets us started, and we'll keep learning every day.